This video is about naloxone, which is just a great drug. It completely reverses the effects of opioid overdoses. And if someone hasn't taken any opioids, it has almost no effect whatsoever. So that makes it harmless in that situation. It comes in pre-mixed vials or syringes, and it also comes in separate vials that can be drawn up into a preparation of your choice. And it works by competitive inhibition at the opioid receptors, so it antagonizes the effect of any opioid that's been taken. The dose for an adult when given IV or intramuscularly is 40 to 200 micrograms, and I'll touch on why you might choose one or the other of those doses in a minute. It can also be given intranasally. The dose is a bit bigger at 1.8 milligrams, but this is really easy to do. You just mix it with some saline, squirt it up a nostril, and the patient doesn't even have to be breathing for them to absorb the naloxone, and you can reverse their overdose. You can give it every 2 minutes, and there's almost no maximum. I think the technical maximum is 10 milligrams of naloxone, so you can give a lot of doses if you need to. And you do have to be careful about what dose you choose. So one of the things you have to think about is, am I going to precipitate withdrawal? And you can make someone very angry if they're very dependent on opioids, and then you give them a big dose of naloxone and completely reverse the effect of whatever they've taken. So with those patients, as long as they're stable and they're not crashing, you really want to err on the cautious side of your doses with naloxone, meaning small doses, and probably want to choose 40 micrograms or maybe 50 micrograms, or even a really small dose of 25 micrograms, and just give frequent boluses until you've reversed the overdose, until the patient is lightly sedated but breathing well. Now, the other group of patients you've got to be really careful of is people with chronic pain who are on really large doses of opioids for a really long time. You clearly don't want to completely reverse the action of opioids in those patients, because they might end up with really severe uncontrolled pain that you now can't give opioids for at least an hour. Whereas on the other hand, if you've got a child who's just got into his parents' medication cabinet, or you've got someone who's took their wife's pills instead of their own and taken the wrong thing, and they're opioid naive and not dependent on it, you can go with a bigger dose and just give them a larger dose of naloxone to try and reverse the overdose quickly. Children get a smaller dose. They get generally 10 micrograms per kilo up to 0.2 milligrams, so up to 200 micrograms. And you can generally err on the higher side of the dosing range for children. And naloxone has a half-life of 1 hour, which is really important to think about, because some opioids also have a half-life of about an hour. So for example, morphine or heroin, they don't last much longer than that. So you can easily give naloxone, and then if you've reversed it, you've probably done enough and won't need to give any more. But if someone's taken a longer acting opioid like buprenorphine or methadone, or if they've taken a long acting preparation of, for example, modified release oxycodone, then you're going to have this issue where the naloxone wears off after an hour, and then they get toxicity again from the opioid that they've taken. So those patients need a lot longer period of monitoring and observation. At the minimum, you need to observe people for 2 hours after you've given a dose of naloxone. I think the recommendations for observing people after buprenorphine or methadone overdoses is like 24 hours in hospital. It's often quite difficult to get people to stay for that long, but you definitely need at least 2 hours since their last dose of naloxone, so you can be sure that they're going to be fine when the naloxone wears off. The other thing you can do with naloxone is run it as an infusion. The indication for this is either you're just requiring multiple doses, or you're not quite getting adequate reversal. And the dose for the infusion is you take whatever dose has been effective as a bolus to reverse their opioids, and then you take 2/3 of that and run that every hour. So for example, someone came in and they had taken a big overdose of opioids, but you only needed, say, 300 micrograms to wake them up, then you might run them at an infusion rate of 200 micrograms of naloxone every hour until you're sure that they've cleared the drug. The endpoints of titrating naloxone are basically all to do with respiration and light sedation. So you want them to have a normal respirate. And I've put normal rather than a specific number because it's important to remember that children have a higher natural respiration rate, and so it needs to be normal for the patient's age. Their oxygen sats need to be 92% or higher. And this is another thing that I want to touch on, which is about giving oxygen. So generally you don't want to be giving oxygen because if someone becomes hypoxic when they have taken an opioid overdose, it's because they're hypoventilating. So what you want to do is fix the overdose and give them naloxone to make them breathe more, not just oxygenate them with 100% oxygen when they're only breathing 3 breaths per minute. And that's a mistake that we see a lot of people make. And the toxicologists that I work for are very keen for people not to be on high flows of oxygen and not have had adequate opioid reversal. So you want to see the sats drop quickly if they're going to drop, so that you can then give more naloxone and get them breathing again, not just let them sit there with a very low respiration rate and oxygen through a mask. And the other thing they need to be is maintaining their own airway. So in terms of consciousness, you want most of these patients to wake up until they're lightly sedated and maintaining their own airway. You don't need someone to be wide awake and furious. You just want them to be sleepy, but not at risk of aspiration or airway obstruction. And as I mentioned before, in terms of observation, it varies. The guidelines tend to recommend 12 hours or 24 hours observation for all opioid overdoses. In practice, it can be very difficult to observe people for that long because often people wake up and they just want to leave. But the time when you really got to think carefully about letting someone leave is when they've had a modified release ingestion or they've taken a long-acting opioid. I'll finally just touch on this paper that talks about bystander administration of naloxone. So in lots of states in America and in some parts of Australia and the UK, people can basically get trained and given these kits with naloxone pens in them, and they're just lay people, so they're not medical staff. Often it's people that are either related to or friends with people that have substance misuse disorders. And if you train the patients and their friends and family in how to use naloxone and when to give it, they can massively reduce the number of deaths from opioid overdoses by up to 40 or 50%. And they're pretty good at recognizing when to use them. They've been studied where they basically tested whether lay people with training were as good at medical staff at recognizing when naloxone was appropriate, and they're pretty much just as good as a trained member of the medical staff at knowing when to give naloxone. So a massively useful public health initiative that reduces the number of deaths from opioid overdoses.